Good afternoon, everyone. Welcome back to iCAAD sessions. My name's Annie. I'm the speaker liaison for this week. It is my great pleasure to introduce Dr. James Stallard. He trained in psychiatry, completing his master's in psychiatry and psychiatric research in 1999, worked as a consultant psychiatrist in the NHS with the West End Community Mental Health Team, and since 2005 he has worked as a liaison psychiatrist at the Royal Bournemouth Hospital in Dorset, where he also runs a private practice in Salisbury and Southampton. Today, Dr. Stallard will be talking to you about psychiatry in the emergency department. He will draw on his long experience as a frontline emergency department psychiatrist with the NHS and describe successful clinical approach which has resulted in reduced emergency attendance. Please welcome Dr. Stallard.
Thanks very much. So yes, thank you for this. I'm very, very pleased to be here. So I'm a consultant liaison psychiatrist in the NHS. I don't exactly know who is in the audience, so I'll explain things as if you don't know anything. So liaison psychiatry is the branch of psychiatry which is involved in the general medical setting. So generally what that means is psychiatrists in a general hospital. So I work in Bournemouth Hospital for the NHS. So I work in there, that's our hospital, and I have a small team, me and a few junior doctors and a team of nurses who provide a 24/7 mental health service for the general hospital. So we see people on medical wards, cardiology, gastroenterology, etc., on surgical wards, and about half our work is in A&E, or the emergency department as it's now known. People still say A&E the whole time, but A&E wanted to drop the accident bit for some reason, and so they're just ED. So that's what I'll refer to them as. And it's a real privilege working in ED. It's fast and furious. It's frontline. It's quite an amazing place to be, and it's really fun being part of that team. People who work in ED on the physical health sides tend to be quite sort of robust people. They've seen it all before. They enjoy being part of this fast and furious team that are dealing with anything that comes through the front door, and it's fun and an honour really to work with them. But one group of people that does get them down and make their eyes roll and compassion fatigue and all the rest of it are the frequent attenders, people who come in again and again, night after night. And I suppose part of the frustration is it's obvious that they're not getting what they want from their visits, the fact that they keep on coming back. So this talk is about frequent attenders at the emergency department, but specifically people who keep coming back with medically unexplained or functional symptoms. And I've been involved in a project at RBH over the last 6 years or so, where we've worked out a successful intervention for some of these people with medically unexplained symptoms, which I will tell you about. So what we need to do really is first of all talk about frequent attenders. Then the main part of the talk will be focusing on this whole business of medically unexplained symptoms, and then at the end I'll tell you about what we did about them. So frequent attenders at ED. So the literature defines frequent attenders as anybody who has visited more than 12 times in a year. We noticed that our most frequent attenders were coming way more than that, and so in about 2014 we set up a regular meeting, a regular group involving me and ED and the ambulance service and alcohol liaison in the hospital. And so we meet every month and we look back over the previous 3 months and monitor the data and think about who are our sort of top 20 or so most frequent attenders. And we found that those people they were coming to us between about sort of 8 and 20 times in 3 months. So they're coming in, every 3 nights or something like that, just again and again and again. And obviously they're very well known to ED, and as I say, eyes roll, and it's all about sort of getting them out again. So one of the things that you quickly realise is that no physical illness brings you into ED 20 times in 3 months. If you have unstable angina, then by the time you've come to ED a few times, you're going to get admitted and get a stent in your heart. Or if you have a very brittle asthma or COPD, again, they'll sort you out if you've got something physical, if it is sortable, outable. So what became clear is that anybody who comes that often has basically got an unmet psychological need, and they keep coming back, and they're not getting what they need, and it's a sort of ongoing, frustrating for all concerned situation. So, who were they? So we found that frequent attenders basically broke down into 3 groups. Certainly far from mutually exclusive groups. There's a whole lot of overlap, but basically 3. So the first bunch are the people are drinkers, people who are alcohol dependent. So yeah, usually alcohol dependent rather than sort of binging or harmful use. And so generally, these are people with a lot of sort of social damage. So they're street homeless, they're in abusive relationships, and they're being found collapsed, and they're being beaten up, and taking overdoses out of desperation, and it's a group with a really high mortality. So in the 10 years or so that I've been doing this, I've known a lot of people who've ended up dying of complications of alcohol use, who were frequent attenders. So that's one group. The next group would be the EUPDs, emotionally unstable personality disorder, borderline personality disorder people. So these are people who fundamentally have an attachment disorder, as I'm sure you know. So that they have hypersensitive attachment circuitry in their brains. And so they have intense, volatile relationships, and they're hypersensitive to perceived abandonment. And when they do perceive abandonment, they freak out and desperately try to recruit care in dysfunctional ways, namely often self-harm. And so this is a group of people who are taking very frequent overdoses, and then coming in and sort of refusing treatment. And they're very hard to manage, as are the alcohol group. But the fact is, there are actually services out there. Services do exist. They're very hard to engage, and they often don't engage, but the fact is, there is actually somewhere that they could go. So, alcohol services, or CMHTs and DBT and all the evidence-based treatments for EUPD. But then there's this third group, the MUS, medically unexplained symptoms people, and the problem basically is that there is nowhere for them to go. The system just doesn't work for them. So let us focus on this, on MUS. So first of all, is there any comments or questions so far on just where we've got to with frequent attenders?
I'd like to comment that maybe it's not getting what they want. Maybe they're not getting enough of it.
Yes.
You know what I mean? They're coming back for more.
Yes, that's a very, very good point. We'll come on to opiate prescribing, for instance, which is one of the things that they want, and they get some but not enough for them. Okay. So let's just focus on this business of MUS, or functional symptoms. So I'll say more about the sort of terminology that gets used later on, but for now I'm using MUS or functional symptoms interchangeably. Okay. So this slide is attempting to show a sort of the totality of all symptoms that people turn up with. So, you know, some people in the green circle turn up with physical symptoms and they have nice, clear physical pathology, and that's all nice, and you know, there's a system for them. That's what hospitals are very good at, and you know, that's what they do all day. Then people over here in the blue circle go to their doctors with mental or psychiatric symptoms, and you know, say what you think about the mental health system or about psychiatric classification. At least there is some kind of system for them, and so they get fitted in, you know, into this system. But there's a whole swathe of people across the whole population, probably involving, you know, lots of people in this room, who from time to time have physical symptoms which don't relate directly to demonstrable physical pathology in the body, in the sort of end organ, and we are very bad at dealing with those people. There is no real service for them most of the time. And this is not a trivial thing. You know, this is a really big problem. It's sort of an elephant in the room for the NHS, really. So this is, I mean, 9 years ago they were saying that the NHS spends £3 billion a year on trying to treat and investigate MUS. More than half of new attendees at medical outpatients have got some form of functional syndrome or medically unexplained symptoms. And I suppose, so what we're talking about is a whole swathe of people. Down one end, it's you know, you or I who have an ache or a pain and we're not sure what it is, and we go to the GP, and the GP says, you know, I can't find any sort of pathology, let's watch and wait and see what happens, and you know, we feel reassured, and for most people, most of the time it sort of goes away and you don't think about it anymore. But for a lot of people that keeps on coming back, and it worries them more and more. And then there's a bunch of people who get really severe symptoms, and they're coming into ED the whole time. But so yes, persistent medically unexplained symptoms is the most common reason for frequent attenders at GPs. One of the features of this group is that they are, because they're experiencing physical symptoms, they're obviously perfectly happy to go to a physical doctor, but they're particularly unhappy at the suggestion that there might be a psychological component, and they're particularly unhappy to engage with mental health services, or anything that sounds at all like mental health services. And because physical doctors can't do much about it, frankly, the whole thing turns into this really unsatisfactory sort of merry-go-round of conflict, really. Okay. So, at this point, in any talk about medically unexplained symptoms, it's traditional to have a go at Descartes, and that's, you know, it's usually people, me included, that have never read Descartes and really don't know that much about him. Have we got any philosophy or Descartes experts in the room? No, please, thank you. Okay, so the sort of noddy version, the kind of having a go at Descartes version, goes that so 17th century French philosopher, and he realised that, or he came to understand that the only thing that he could be sure of was his own thought. The only way that he could prove that he existed to himself was through his own thought. So that's cogito ergo sum. And by realising that, at a stroke, he's divided the universe into mind stuff, res cogitans, and everything else in the whole world and the whole universe, res externa. And so you know, in that moment, he's set up this mind-body dualism, Cartesian, from Descartes, Cartesian dualism, and that seems to have pervaded Western thought ever since. And so we live, particularly in the West, in a very dualistic system, and I think we're all part of that. I mean, I still, as you can hear, still talk about physical and psychological. I think it's really hard to reconcile them, truly reconcile them into one holistic thing. But viewing them as very separate is certainly unhelpful, and just doesn't reflect reality. And so we can all blame Descartes for that. Okay, so I've sort of alluded to the fact that it's hard to think about this phenomenon, and you can think about it, and people do think about it from lots of different angles, and use lots of different terminology to describe it. So let's just think about some of the ways this whole mass of different symptoms that people present with that don't seem to relate to clear pathology. So people turn up with all kinds of pain, abdominal pain, chest pain, jaw pain, pain in limbs. They turn up with tiredness and exhaustion, or sort of brain fog, and all kinds of symptoms like that. And so how do we describe it? How do we chop it up into different entities, or do we view it all as one big whole, one big thing? And so that the medical, the physical medical approach historically has been to split them up into lots of different bits. So if you go to your GP with aches and pains, you will probably end up in front of a rheumatologist, and they might give you a diagnosis of fibromyalgia, for instance. If you end up in front of a gastroenterologist, you might end up with IBS or functional abdominal pain. And there's a lot of value to this, right? So if you are that person and you're in front of the doctor and they listen to you and they sort of understand you and they give you a diagnosis, that's validating and helpful in many ways. But it does medicalize you. It does make it sound like you've got a medical condition that sort of medical doctors understand in some way, and the fact is they don't. And I think that does, it sets up problems. Because so if you look at all these different functional syndromes, and so the question is, are they truly separate, or are they all the same thing? And all through the 20th century there was an expectation that if only we were, that in the end we would be clever enough to work out what the cause of chronic fatigue or fibromyalgia or irritable bowel is, but it hasn't come to pass. We just haven't found a common pathology. But what we do know is that broadly speaking, the people that have one functional syndrome are quite similar to the people that have other functional syndromes. So the fact is that females are overrepresented, people who've experienced child sexual abuse are overrepresented, people with psychiatric comorbidity are overrepresented. So the groups look quite similar. And then if you look at these syndromes, that we realise that there's an awful lot of overlap as well. If you have fibromyalgia, you're very likely to have sort of fatigue problems or bowel problems. So Simon Wesley, who's the ex-president of the Royal College, and he's a liaison psychiatrist and done lots of work on this, and so his conclusion was that the separation is an artifact of medical specialization, and actually really what we're talking about is really all the same stuff, just manifesting in different ways. And they're probably not discrete entities. I should say that I am aware that this is a controversial area, and people feel very sensitive about this, and I can understand why, because these are horrible conditions to have, and they feel very physical, and it's very difficult to shift from that position. So and I know that it's a very common condition as well. So just to say that I'm being really careful, because I am aware that it's very sensitive. Okay. So there we go. So this represents. It's not very PC with sort of people with you can't see properly. But anyway, it sort of represents doctors who are sort of short-sighted, let's say, and all they're seeing in front of them is this thing, and they think this is the problem, and that what they're missing that is actually part of a great big elephant, with other doctors crawling all over different bits. So the view from liaison psychiatry, and I think I share it, is that that these are really probably manifestations of the same sort of central process. The other thing I should say, actually, another caveat, is that obviously we need to just keep an open mind about any physical causes. We do know that people with Campylobacter infections of the gut are more likely to get irritable bowel, and people who've had glandular fever are more likely to get chronic fatigue. So I'm certainly not saying that there is no distal pathology. We just don't understand it, and I think that there's a very big psychological component going on here as well. So that's that. So, looked at from the psychiatric side, so the diagnoses that have been open to us traditionally are these somatoform disorders and somatization disorder, and frankly, they are pretty hopeless. That there's certainly if you're an ED and somebody's rolling around in agony, abdominal pain, and you sort of try and explain to them that they've got a somatoform disorder, you're not going to get anywhere, and it doesn't really help. There's not really a good evidence base for treating them. So, to be honest, in my experience, liaison psychiatrists generally don't really use these diagnoses, and I think they're on their way out. So this sort of refers again to this business of how sensitive one has to be in the terminology that we use, how we talk about these things. So this is a sort of this is an article that appeared in the BMJ in 2002, and it's a sort of funny medical joke about number needed to treat in clinical trials. That's a way that you measure effectiveness, and so his thing is number needed to offend. And what he's looking at basically is the terminology that we use and how acceptable or offensive it is to patients. And so he's looking at people with functional weakness, and looking at what they find acceptable and what they don't find acceptable. And not surprisingly, being told that it's all in your mind is what they find most annoying. Even more annoying than hysterical weakness, which is pretty annoying, I'd say. Medically unexplained is sort of middle of the list, and the thing that's most acceptable is describing them as functional. And so actually, although I have historically, to be honest, used medically unexplained symptoms, I think we're all swinging back towards using the term functional. By which we mean, it's not that, let's say, the gut is damaged in some way, it's just the way it's functioning, or the nervous system is functioning. And we quite often use the sort of hardware-software analogy of, your hardware's okay, but your software isn't functioning quite right. So that's that. So yeah, just to let you know that there is this new diagnosis which I think is quite useful and which people seem to be using more and more. So this is from DSM-5, the American classification system, came out a few years ago, and so they have provided this somatic symptom disorder as a diagnosis, which is it's very broad. So it just says that you have to have 6 months of symptoms which are distressing, and that your thoughts and feelings and behaviours around them are disproportionate. So it's pretty vague, but I think it's useful, and I think it sort of is a step towards describing really what's happening in reality. It has been criticised because, obviously it potentially brings millions of people in under the umbrella of mental disorder. But I think it's helpful, and actually ICD-11 I think is going to drop the somatoform diagnoses and have something called bodily symptom disorder, which is going to be very similar. All right. So in this slide, all I'm trying to do is illustrate that all of these syndromes and symptoms exist on some kind of spectrum, which and so everybody is going to have a different combination of a physical component. Excuse me for being dualistic, but a physical component, which is the dark blue, versus a sort of psychosocial component, which is the lighter bit above. And so if you put all these functional syndromes on this spectrum, right down the far end, where there's a lot of physical pathology and a little bit of psychological, you might have something like COPD or asthma. So somebody who's genuinely got a sort of a horrible illness, and they're very anxious about it, which makes them even more short of breath than they would have been anyway. They've got a whole lot of physical and a little bit of psychological. And then down this end, you could put, let's say somebody who has had some kind of psychological trauma and now presents with weakness down one side. I saw a soldier a few years ago who'd been in Northern Ireland, and he'd been in a bomb blast, and his colleague was to the right of him was killed by the bomb protecting him, and ever since then his right side had sort of had intermittent weakness, and he presented with paralysis down one side. He really did have no physical pathology at all. It was a conversion disorder. So that would be down this end, and then you'd arrange all the other functional syndromes somewhere on that spectrum, keeping an open mind about physical component, but acknowledging that there is a great big whack of psychosocial component going on as well. Okay.
Can I ask what happened to the soldier?
I don't actually know. I'm so sorry. No, yeah, sorry.
But you would have referred him to a psychologist, and
Yes. Yeah.
he would get over the trauma.
Yes. Yeah. He would. Yeah.
Sounds like.
Yeah. It was happening intermittently. I think he would have come in. What quite often happens with conversion disorders is they come in and physios work on them, with a kind of positive expectation that they're going to get better, and they do. So quite often it's intermittent, and I suspect that's what happened to him. Right. So yes, all I'm trying to do with this slide really is illustrate that the problem is not just in the patient. The problem is with the patient hitting a system which doesn't help them. So you have a system, a patient who's got some kind of physical vulnerability, plus some kind of psychological vulnerability, alexithymia, difficulty in describing feelings, or attachment disorders is a big part of this. and they start to experience functional symptoms, and then they bump into a system which is full of busy, defensive doctors who investigate the hell out of them, and when everything's normal, they do all the investigations all over again. And they might even go to a surgeon, and if you knock on a surgeon's door for long enough, they will do an operation, because that's what they do. But then in the end, after all of that, umpteen investigations and operations and everything else, in the end they'll say there's nothing wrong with you, clear off, and that's obviously incredibly dissatisfying for the patient, and so you end up with patients with huge, great thick notes and repeated unsatisfying encounters, and that's certainly what happens in ED. So I'm talking about the sort of the top end of the MUS spectrum, and they're coming in and they're complaining, and their families are sort of shouting, "You've got to do something," and it's all very heated. Okay. Right. Okay, so this slide. So here's where I need to do I've got some explaining to do. So I've found this whole business of functional symptoms a difficult thing to get my head around. I think it's really hard to get a feel for how it could possibly be that somebody could experience, agony in a part of their body that doesn't have anything any physical pathology. How could it possibly be? What is happening in their brain? Because they're not lying. They really are experiencing this.
So fabricated illness disorder, is that on this scale, or is it like the other end?
Do you mean what, people who are aware of?
I'm not really sure. Like maybe sometimes people might be aware that they're fabricating, but then maybe they might lack insight that they're doing that. So maybe there is some physical, but then
Yeah. I mean, it is mixed in with it, and it does overlap with it, but then that's got a component of something deliberate, which we do see all the time. People picking at wounds and making them infected, and there's something about getting care. There's something about attachment and getting care which is intrinsic to all of this, really, I think.
That's at the far side, but this is more like somebody can't help it because it actually experiences something, but it could be psychological.
Yes, yeah. It's definitely in part of this picture, yeah. But that's another sort of layer of behaviour on top of all of this. Okay, so look, what I'm trying to say here is that there's a model that I've found really helpful in just sort of getting some kind of feel of what's happening, and it's based on this business of predictive coding. So this predictive coding is a sort of one of the the kind of modern, trendy, cutting edge idea in neuroscience about how the brain works, and it's basically seeing the brain as a predicting engine. Everything it does at every level is about predicting, and it's incredibly complicated stuff, and I don't fully understand it at all, and sort of it's big in the AI world. What I'm trying to take out of it is a really simple kind of noddy model that I can just hold in my mind, and it just helps me sort of get what's going on. So it's predictive coding. It's also, you may have heard of the Bayesian brain is another theory, and actually, if you're interested, Carl Friston is a psychologist at UCL, so local London boy, and his theory is the free energy principle, and it's a really amazing, cool theory. So I do recommend that, but it is unbelievably complicated. So essentially, what all of this is saying in a really simple way is that the cortex, the outside part of the brain, the thinking part of the brain, is made up of millions of layers of neurons, and the neurons and information passes, broadly speaking, from the lower layers up through the layers, and there's connections from the lower layer to the next layer up. But there are also connections back from the layers above back down that modify the information that's coming through based on prediction, right? So what it's trying, what the brain at every level is trying to eliminate is surprise. It's trying to just predict what's going on all the time. Because if you're an animal walking through a forest and you're constantly surprised by everything, then you're in danger. And what you want to do is predict what's going to happen. So if you, and I think there's a talk on chronic pain tomorrow, which will be, I think, saying sort of similar thing. If you stub your toe, the impulses come up through your nerve and through your spinothalamic tract and into your thalamus. And at this stage, they're not pain; they're just impulses, and then it moves into your cortex and starts being experienced consciously. And all I'm saying really is that there's a top-down modification of how that information is managed based on what's happened before and based on the person's beliefs and their hopes and fears and what they're anticipating. Okay, so I realise I'm struggling through this, but the point is that any perception that we have is a combination of input from below and this whole cascade of prediction that comes down through these layers. And so, and that's how the brain works, we think. And so you can start to see that, if you had very minimal or even no input from below, you could still have this cascade of prediction of perception.
Is that based on past experience?
Yes, I think it is. I mean, it's based on everything. It's everything about what the patient's predicting. It's and attending to, so that they're anticipating pain, let's say, and they're attending to that, and they believe it's going to happen, they fear it's going to happen, and it does.
So this is, in a sense, the unconscious predicting.
Yeah. I mean, yes, absolutely. It's. I don't know if. I'm quite interested in this field called Neuro Psychoanalysis, which is trying to link hardcore neuroscience with, I mean, broadly speaking, psychoanalysis, but not strictly speaking. And so that's it. It's so when we imagine what the unconscious might be, it's probably something like this.
So I'm just thinking of
What's part
therapy
of it?
being the essence of therapy is making the unconscious conscious. So, whether functional symptom people are open to therapy or not saying that therapy is going to be a cure-all, but I'm just interested to hear how you proceed with the next stage.
Yeah, okay. I suppose therapy, broadly speaking, therapy that's dealing with the cortex is I think of in very, very, very simple terms as more to do with sort of CBT type therapies, because it's thinking and believing and those kind of things. Whereas psychodynamic is probably dealing with deeper parts of the brain, probably basal ganglia. I mean, we don't know this. This is it's all conjecture, really.
With the hypothalamus the amygdala, because isn't it followed by compulsion to act? These thoughts and symptoms, are they followed by a compulsion to act in some way? You said seeking attachment is one.
Yeah, I mean, I think I do think that attachment plays a big part in this, and so it's all part of. It's not just happening in the patient. It's something in the relationship with the doctor or the hospital as well. It's something about not being listened to, not being taken seriously, and that amplifies everything.
So there is an anger there too.
Yeah, and yeah.
It's frustration.
Yeah.
and a need for something that you're just
Oh,
not getting. You know,
It's
how,
irrational.
mm,
It's quite
yeah,
irrational.
yeah, yeah.
How do you account for like potential bias within staff? Then that sort out attachment. But obviously not people like in its entirety, but like there could be, something going on. But if everyone's annoyed or other types of biases, then that's.
Absolutely. I mean, that's absolutely the problem. Is that all the staff, are, most of them are full of bias because it just doesn't fit into what they do. They're trained to, fix your broken leg or whatever, and they do that brilliantly, But they just, they ring us and go, "We've got another one for you. We've got a mad one for you."
Yeah. Are you able to engage ED staff in any type of?
Yes. Yeah. We are. Yeah.
What does that look like?
So it's partly ED staff and partly let's say the gastroenterology team, and yeah, we sort of do psychoeducation, and some of them want to get it more than others, and so we work with the ones who sort of are interested in this kind of thing. I mean, I'll say a little bit about that later on.
I really apologise for interrupting. I should have asked this earlier. You said females are overrepresented. You didn't say how much. You represent what the actual number is, and because it could be gender political. So it's good to know that.
Yes, and I don't have that number, I'm afraid.
A lot, or a little bit, or massively, or what?
It's not going to be massively. I mean, my take on that, again, this comes back a bit to Neuro Psychoanalysis, is that attachment does play a big part in this, and we know that testosterone dampens the panic grief arm of the attachment system. The fact is, broadly speaking, on across the population, male attachment systems are slightly dampened compared to female, and personally, I think that's got a lot to do with why depression and anxiety are more common in women, and probably this as well. And other things like antisocial personality disorder and those kind of things are more common in men. Very, it's controversial. And, anyway.
How many people are you studying then to come up with that diagnosis in your practice? You said there's a comment. How many in your study are you looking at?
I'll come on in this study just 25, but I mean we see other people like this all the time.
Had child sex abuse or trauma or emotional attachment?
Yeah, I mean that's from a that fact is from a well-known, well-cited paper from before. So I'm just.
And you're seeing that in your.
Yeah, absolutely.
Really?
Yeah.
Or female child sex abuse and trauma and attachment disorders.
Yeah, I mean, it seems to be an accepted fact that there are more female. I mean, what I'm seeing, what I experience is more about you can sense that there's attachment and problems and psychological issues. I haven't really thought about whether there's more female or male.
It connects with the ambivalence that you described, that anxious attachment of going for care and then being angry that the care is not quality care or
Yes.
perceived quality care. My question is, as I understand it, is this all happening in the first 18 months of life, that attachment, the internal working model that then is completely unconscious, but is that what, I haven't read these books, but is that what the theory is essentially saying?
No, I don't think this theory is saying that. I mean,
The neuropsychological, that formation of that
recognition or monitoring for constant danger is learnt in the first 18 months, when survival is basically, if you don't navigate that, you won't survive.
Yeah.
That's the question.
Yeah, I don't think it's saying it's exclusively first 18 months, because I mean the whole business of attachment disruption is, I mean, there may be a first 18 months component, but also being any experience of abuse later on is also an attachment disruption. But I'm not saying this is only about attachment, because it's also about all your beliefs about medicine and hopes and fears and beliefs, and it's just everything. It's the whole concoction is what creates these symptoms. I mean, very often actually people do have really what are called abnormal health beliefs. So they really are convinced that but there must be a constriction in my bowel, or that there must be something wrong with my whatever elbow, or and they're absolutely convinced that because some doctor somewhere along the line has said, I think you've got joint dysmobility or something, and so they've taken that, it's all about becoming invested in all these beliefs that they have that are really unhelpful. Okay, so moving on. So I've put this slide in really just as a nod to the fact that I'm at iCAAD and I wasn't quite sure who's going to be in the audience. Just really to say that this whole business of functional symptoms, functional pain, obviously in particular, has got a huge relevance to the business of opiate overprescribing. So I mean, we all know that there's a catastrophe unfolding in America. I was at a conference the other day with a pain specialist who was saying that by the end of next year, 1 million people will have died of opiate overdoses since this crisis. So it's just a disaster that's happening, and it's not as bad here because of different environment. But we need to be really careful, and certainly in my practice I see all the time overprescribing of opiates, and that's partly because opiates, I think, again, the attachment system is partly mediated by endogenous opioids, and so even though it doesn't get rid of the pain, they don't want to stop, because it does. It makes it feels nice, for everyone it does, but particularly if you've got attachment issues, and so it's just a real risk, and I think it's important. It's just an important thing to understand in terms of risk of opiate overprescribing. And I know there's other talks about chronic pain, and I'll probably say more, but basically opiates shouldn't be prescribed in chronic pain. So there we are. I was just saying something about opiates for iCAAD. But it is a big thing in this whole business. So actually, there we are. So that's the end of the MUS bit. So and in the last bit, I'm not sure how long we've got left. 5 minutes. Okay. So all right. Well, so I'll press on and do the last 5 minutes, which is very quickly what we did at RBH. So we took, from our frequent attenders meeting, we took 25 of the absolute, number one frequent attenders with MUS. So over about 4 or 5 years, we took the 25 real creme de la creme kind of thing, and we recruited them, and then we also they also have a frequent attenders meeting at Poole Hospital, which is in the next door town, and so we identified 25 of their top frequent attenders, and so they were the control group and ours were the intervention group, and so we did an intervention. And so we've talked about the fact that engagement is going to be key. If we just wrote to them and said, hello, I'm a psychiatrist, can you come to the mental health unit to talk about your pain? Just no way, not in a million years. So we often actually went to ED when they were there and invited them to come back to ED, next week. And so, so we're seeing people in the environment where they feel like they want to get help from. And so they'd come and meet us. And again, we're not trying to say we'll cure you of your, all in your mind symptoms or anything like that. That's the last thing you want to say. So what we were trying to do is help them cope with their horrible physical symptoms. And that sounds acceptable to people, saying we're part of the gastro team, and that's because we are actually, we're not, we weren't lying. So it was all about engagement. They haven't been listened to. They've been sort of cut off and sent away repeatedly. So it's important to to listen to the whole thing, and so bleed the symptoms dry. Really talk about the symptoms in a lot of detail. So then you've got a therapeutic relationship. Ooh, I'm not going to go through this. This is my special slide that I've created. So I give this to sort of junior doctors. This is basically a whole load of prompts of how to take a good history in somebody with medically unexplained symptoms. So all the different factors that you might be looking for in a history. So briefly, things like childhood experience of illness or parental illness. If because there's a lot about the sick role as well. The sick role does excuse you from certain stresses in life. And if that's something that you've seen in action in your childhood, it's a road you may well go down. Anyway, so there's lots of factors, and so this is what we're doing in our assessment, taking a good history, and coming up with a formulation, identifying all the different factors that have brought them to this experience. Yes, sorry, I will just now say, because I had added another slide. So what we do, after the assessment, what we then do is liaise with their medical team and ensure, as far as we can, that there is clarity about what is and isn't wrong, and what can be done and what can't be done, because often they're engaged in this endless grind of one more investigation, and just waiting for another investigation. So it's important to have clarity, draw a line under the investigations, and then something that we had to do for quite a few of these people was actually admit them to a medical ward and detox them off their opiates that they were on. So lots of these patients were on fentanyl patches and things, and we had to make the decision with the patient that it was time to stop the opiates, and so that was a whole piece of work in itself, obviously. So once we've done that, then we move on to the CBT phase, and so most of the evidence around functional syndromes is to do with CBT, and actually the psychologist that I work with is a CBT psychologist, so that's why we did CBT really. So she offered them 10 to 16 sessions, average of 12. I won't go through the protocol because there's 2 books that she based this protocol on. So the bottom line was there was a whole lot of intensive engagement and assessment, a whole lot of liaising with the medical team, then a whole lot of CBT, and the results actually. Just to say that we did the PHQ-9 and GAD-7 on everyone, and the work and social assessment scale. So it's about work and social functioning, and in our intervention group, lo and behold, we got some good reductions in depression and anxiety and social dysfunction, and the thing that the hospital liked was, so that the 2 blocks on the left-hand 2 are the intervention group, And so on the far left, we've got ED attends before the intervention and then afterwards in the green. And then these are bed days used before the intervention and after the intervention. And you can see it was really successful, and so they attended far less, used fewer bed days. This is the control group where there was no, so this was highly significant, statistically significant, and there isn't much of a change. So it was very successful intervention, and the hospital liked it and carried on funding it, which says it all in the NHS. All right, so there we are. So conclusions. We might have time for a question or two if there are any, but the conclusions really are that people with MUS are incredibly frequent attenders. They use a lot of resources, but it can all be improved with a CBT. It's really a CBT and case management intervention, but engagement is key. There we are.